take over. Hi, Frank.
Hey, Craig, how you doing?
Fine. We've got a great panel up here, and tell us what you've got.
Well, I've got quite a number of things. I was taking a little break there. We've been in here working away because this is a little more complex than what we thought it would be. We've got a fine 69-year-old gentleman who has known coronary artery disease, peripheral vascular disease. He smokes a cigar every now and then, but came in with ABIs of 0.49 on the left and 0.6 on the right, and had symptom limiting rather for 3 claudication. And so we brought him in and did not have a CT or anything, so I really didn't know what I was getting into, except the SFA looked like it was pretty ganked up, I guess you might say. And let me show you the first picture we took here. Now we're going to run this. This is his left lower extremity, and we did a angiogram. As you can see, he's got a short nub there, and his profunda comes off nicely. Then he's got a total occluded SFA that reconstitutes down just above Hunter's Canal right here. And actually, what's excellent, he's got excellent runoff. Now, this is the second time we've worked on him. It was not that stenosed when we had worked on him previously, and he kind of got lost to follow up a little bit. And then when he did show up, he was hurting pretty good and didn't come back in for the follow-up Dopplers, and that's kind of where we stand right now. So we've been kind of working here offline to speed things up, because I know we're always stressed for a little bit of time trying to get everybody in. So what we did was I went through, and as you can see, this is an angle shot showing his short stenosed SFA here. And then what we did, we crossed it with a wire. What I did is I took I like to use an angled aquatempo catheter, which is actually a vertebral catheter, but it gives me a lot of good push on the back. It's a 5 French, and that's a hydrophilic wire. And we crossed the total occlusion. Actually, interesting, even though it folded over, we stayed pretty much in the lumen and came out pretty well right here. And so that's where we're at. So went through here, and where is it? There you go. Took a 2.3 excimer laser and performed laser ablation and made several passes going up from 60-60 to 60-80. And this is our results. This is where we're at right now. So this is our results after laser alone, which is pretty good. And what our plans are now is to pre-dilate, which we're in position now with a 6x250, and 6x250 Pacific balloon, and we're going to pre-dilate and then go with drug-coated balloons. We've got two. It's going to end up taking 3 Lutonix balloons, I believe, to really get this. All right. I can't hear anything. I assume they heard me.
Frank, you're doing great. I'm sorry, I was on the phone here.
Oh, okay.
I apologize.
Oh, okay. That's
lovely,
all right.
Lovely start.
Be sure to get
case.
the milk now. All right. And so let me show you a couple of things while we're here. As Craig, as you well know, I had some problems, physical problems, and actually thought that I wasn't going to be able to work in the cath lab anymore, but it worked out well. I actually have my Darth Vader suit right here, and this is a 0 gravity, and this has actually allowed me to come back in the lab and work. And when I didn't think I could, and this is just a lifesaver. My back feels better than it ever has. I wear no lead. And I use this. This is a heavily leaded with leaded glass shield that hangs from a boom. Now it does kind of basically take up a little room in the cath lab, but I'm pretty much able to do any kind of procedure I want to do, from putting in pacemakers to AAA devices to pedal sticks with this device. It takes a little bit getting used to. And what you do is you step into it. There's a magnet vest that hooks in, and we can work from there. Now, I don't know if you can hear me as well when I'm in my they call it the barrel, but that's where we stand.
That's cool. And Frank, you mentioned to me that you got a lot less radiation as well, right?
Yeah, we actually, I don't know if it's still, yes. We put a high sensitive radiation sensor right here, and I did 3 cases that day, long leg cases, and I had 0 radiation on it from the inside. So I'm well protected. That's not an issue. So we've got a balloon in place. We're going to inflate this, and we'll talk. We're not going to leave this up like usual because we're going to go in with with some drug-coated balloons here in just a second. And all right, go on. Slowly go up.
What balloon have you here?
This is a Pacific Extreme by Invitec. It's a 6 by 250. We're going to slowly go up. I think we got pretty decent debulking from the laser. And I think it's going to pan out in the future that you're going to need to debulk. And you got a little area there. It's getting a little trouble in it. And nice. There you go. That should be good enough right there. What you up to? Okay, that's perfect. And I think debulking before the use of drug-coated balloon is going to pan out to make a large difference.
Yeah, I think that's going to have a role as well. So, Frank, how long are you going to dilate?
I'm going to dilate for 30 seconds on this particular balloon, and then when we put the drug balloons in, even though they tell you that a large amount of the drug will come off in 30 minutes, I like to leave them up for 2 to 3 minutes because most of the studies have been done with 3-minute inflations. And that's why we kind of hustled through this case so we could get that part done. Come on.
Yeah,
now.
I've never seen you dilate for 30 seconds. That's unusual.
I know. This really, this is real unusual. It makes you a little, it is unusual. But we're going to leave the next one up a little longer than this. I'll actually take my seat here in a minute.
I noticed you don't have your helmet on that you used to wear.
Oh, we might have something big a little bit later on. But let me show you something here also. If you look on his leg, you see I have a ruler. That's actually a new Spectranetics ruler that's out, and we've been using it. I told Claude it was nice of them to package it in with every laser, and it didn't cost anything because they come with the lasers. But Claude told me that's probably not true. But we've been using it as markers, and that way we're able just to keep moving here. Let's take a picture and see what we look like.
For the audience, it's crucially important if you're going to use a drug-eluting balloon because you want to make sure you don't have geographic miss. Looks pretty nice, Frank.
I think so. Okay, we're going to go in with our first one. Now, for the people that do not have the drug balloons at this point in time, what you do is with this particular balloon, you have about 3 minutes to get it in position and inflate it. I'm going to inflate proximal to distal. And you actually have to, we'll demonstrate with the next balloon, I guess, but what you have to do is you kind of break it up while it's in a little sheath before.
So, Frank, this is the Lutonics, right?
This is a Lutonics.
And what length balloon?
This is a 6 by 100. It's the longest they have right at this time, but they're going to come out with the longer ones pretty soon. The 6.0 is the largest diameter that Lutonics has.
This balloon uses polysorbitol as the excipient, and it has and paclitaxel as the drug that's being delivered. It has very nice adherence of the drug to the balloon, and the excipient facilitates drug delivery to the artery.
There you go. So with the markers we have by our our ruler, it actually helps us with geographic, okay, go up. It helps us with geographic miss. What's the number on this thing? 6. We're going to go up to, slowly go up to 6. We'll let this thing sit here for about 2 minutes. And I'm going to step out of my Darth Vader suit, come over here and grab a seat, and let Blake take it on up. Step on that floor over there, Blake, just to make sure there, buddy. All right, that's good. Take a picture of that for the lawyers. Thank you. So, and this is kind of the standard way I've become to treat a lot of these, especially since January when we've had availability of these balloons, and have been having some pretty good success. As you well know, I'm not a big stenter, Craig. I'm really not. And I think not leaving a lot of metal behind may be a good way to do this.
Yeah, there's certainly a lot of people that agree with that. And so, Frank, it is your idea that you're going to use 2 or 3 balloons here? Is that what you're thinking?
Well, by using the markers here, if you look at the markers, we go all the way down to almost 25. Let me see if I can, right there. You can see where it's right almost at 25. So I think it'd be best if we use, I'm going to use 3 balloons now. I mean, if you think about it, that gets a little pricey. But it'd be nice when they extend the length of the balloon where we'll be able to use less balloons at a lesser cost. But, you know, I hadn't had any complaints from Bard lately about using 3 balloons on a case. They hadn't said anything to me, so the hospital has, but Bard hadn't had a word, you know, and neither has Medtronic. So, you know, they kind of not saying much about that. We're at 150, 151. They say at about 30 seconds, most of 60% or so of the drug comes off. So I know this is highly unusual. We got 2 more balloons to put in there in a short period of time. So we're going to start coming down real slow.
Frank, if
we're going to get the next balloon, and Blake here is going to show you how to prep the balloon real quickly after we get this one out. Go ahead and hand me that balloon there.
Great. And then, Frank, after you show that, perhaps we'll go back to Thomas Zeller for just a second to see his final result and come back to you, if that's okay.
That's fantastic.
So I'm
going to let Blake show you how to prep this real quickly, and then you can leave. So when you take this balloon, you have to, you see how, show Blake's hand right here, yeah? Can y'all see his hand? Okay. Yeah, it's got a sheath on it, and you basically kind of activate it and break it up by that, and that's how you do this particular balloon. And then when you flush it, you got your flush, there you go. Did you label that?
I did.
Blake got in a little trouble about labeling one time. So you aim it down to make sure that it does not get wet, and then when you handle the balloon, you definitely need to handle it with a 4x4. I do not touch the balloon if I can help it. So Blake's going to take this and secure it, and we'll get this other balloon out. We'll do our inflations, and y'all go ahead and see Tom, and we'll get back to you here shortly, okay?
Yep. Great job, by the way, Frank. So let's go back to Dr. Zeller at Bad Krozingen.
All right. They're going to...
Dann bitte nochmal Durchleuchtung.
Hi, Tomas. We're back with you for a second and thought we would see your final result.
Yeah, here it is. So basically what we did, we positioned the stent at the level of the thrombosed origin. You can see that the stent struts are already a little bit expanded like a funnel. And this was done by intention to let the stent struts protrude a little bit into the bifurcation in order to completely cover the occlusive thrombus and to create a channel without being at risk of thrombus prolapse into the stent following the post-dilatation. And this is now a conservative post-dilatation. We implanted a 10 millimeter stent into the common iliac based on the CT angiogram, where we have seen an 11 to 12 millimeter outer diameter of the common iliac artery. This is 8 millimeter post-dilatation. I don't want to squeeze thrombus material through the meshes during the post-dilatation procedure. The external iliac stent was post-dilated with a 7 millimeter balloon, and this is now the final result. There is also some disease in the left common femoral, could be even a mild spasm due to the chronic hypoperfusion. I'm not intending to dilate the common femoral. So we are done with this result. We checked also the outflow. Everything is fine as it was before we started the procedure.
Tomas, a beautiful result. You made a really, really tough case look very easily doable. Beautiful job. Thank you so much for a great job.
Thank you. See you later.
Thank you, Tomas. Okay, let's go back to Mobile, if we may.
Oh.
Okay, Frank, we're back with you.
Do it.
We want to learn how to be Darth Vader too, Frank.
Well, I'm going to be honest with you. I wished I had this thing 10 years ago. I wouldn't be in the shape I'm in if I didn't. And I really wouldn't. And drop that other balloon. And it's made all the difference in the world. The interesting thing about this thing is when they were in here, you had to go through a little period of training. And while we were in training, I would, have to hold it with my hands like this and work, and it was cumbersome, and I kept thinking, well, this ain't gonna work. And the rep kept telling me, wanting me to put the magnet on. There's a vest and a magnet underneath. See, I can turn and hold it like this. There's a magnet underneath it. I was very resistant. I mean, I don't know how you think about all cardiologists or interventionists. We're stubborn as hell. And so I finally, the very last day, put it on. And all of a sudden, I could do things that I couldn't do. It's just like it's almost like wearing lead. And I turned to him and I said, well, why didn't you show me this before? And he said, I tried. And I said, no, you didn't. But it has made a huge difference by wearing this. We're at 2 minutes, start coming down. So we have one more balloon inflation after this. And go ahead, Blake, take it out. Hang on just a second. Let me take a peep. Let me take a picture. That way we'll know where we are. Okay.
And Frank, that's perfect because you've got about 2.5 minutes left.
Oh, that's good. We need to move quickly, guys, because we got 2.5 minutes, and we're going to.
Yeah. We can extend a little bit if we need to, but you're doing a great job.
Well, I want to at least get you a final picture here. Get that other balloon
So
ready.
Frank was bringing up the point about dilating from proximal to distal. And I think it's an important point. He's got a marker band. He wants to make sure there's no geographic miss with the drug. That's why he has markers. He also wants to make sure he doesn't wipe the drug off as he goes through any high-grade stenosis. So by doing this proximal to distal, he ensures drug delivery.
So it sets at 20. Okay.
You can tell Frank hates what he does, can't you?
Did we go fast? Yep, there we are right there. All right. Pull back a little bit. We got a little overlap. Go up. Slowly go up. We'll make this last dilation, and then we'll take a picture, and we'll see how it looks. But I think we're covered real well. We went down to 20. We've overlapped about 10 each time. And I do believe that just to ensure that you have, I'm trying to get the echo out of here, so, but just to ensure that you do cover the lesion, it's okay to overlap. You're not going to have a problem with that. I don't think there's not as much drug on there as there has been, like when they had the candy wrapper effect with the coronaries. and using paclitaxel when it first came out years and years ago. So I think we're going to get good results. If you'll look at his initial angiogram here, he has excellent runoff.
I think it's also very important.
I think with this runoff, what we're going to do is what I'll do is I'll take a regular picture here, and then we'll do a DSA runoff if we still have time. If not, at least you'll see what kind of results that we'll have here.
And I think it's also very important to emphasize the pre-dilation before the deployment of the drug-eluting balloons. Could you comment a little more about that?
Well, I agree with you. I think the pre-dilatation is important for now. Sometimes if you've got excellent debulking results, you could go in and do a primary delivery of the balloon, of the drug-coated balloon. But basically, I believe that you probably should, because the least amount of any kind of friction on the balloon that could knock the drug off or actually disrupt the drug on the balloon, I think should be addressed as best you can before you do deliver the drug, because you're just trying to get the drug in place to inhibit mitotic division, which it does. And actually, it's a cidal drug. If paclitaxel is, it's not an inhibitory drug, retrospectively thinking. So, all right, start coming down. And so we're going to come down right here and get us a final picture. Craig, you've got quite a panel up there that's pretty quiet. I've been surprised.
Yeah, I can't imagine it.
Yeah, me either.
That might be because I talk so much.
or the microphones. No, but I think the.
Well, I did go up there and turn all the microphones off before I left the other night.
Yeah. No, I think the case overall, I think the strategy was very good. Contralateral antegrade access to cross the lesion. I think that the bulking was definitely very important. There's more and more data coming out about the bulking although not specifically with laser, but also with other atherectomy technologies that appears to show that DART, or direct atherectomy, and drug-eluting drug-eluting balloons may be associated with better outcomes. And the beauty of this is you're not leaving any stents behind. This is really state-of-the-art therapies. And if the patient does develop restenosis, which he would have much less chances of developing with all these therapies, even a future intervention would be less of a problem without the metal there.
Frank, that looks like a nice result. We just need to make sure nothing's embolized. Unlike...
Yeah, I'm gonna run this entire leg here in just a minute, so...
Okay, great. We have about a minute left, and so that's good.
Okay, you wanna hook up and we'll run this leg? Here's your wire, buddy. Spritz. Back. This is as you remember, for years and years, I've used this Toshiba unit for a long time, and I really like Toshiba. I know the equipment very, very well, and it just makes it easy when you can run your panel and get things done. Lock me side to side, Blake. Right there, buddy. Okay. You ready? Go. One more. You ready? Go. 6 for 42. All right, we're going to run this leg now, and we'll see what we got distally, and we're hoping for a real good result, and this young gentleman should do very well.
Again, also very important to always assess for potential distal embolization at the end of the intervention.
Yes.
Never to take a shortcut. It's very important to know your baseline and your final result. Even if you have previous studies, like such as CTAs or whatever, it's very important to always assess for it.
Great. Very nice.
Frank, quick question. What long-term medical therapy, since I just gave a talk about medical therapy, what long-term medical therapies are you thinking about placing your patient on?
Well, you know, I actually like to use Salacizol quite a bit, and I do use that. There is some data in the coronaries from Japan that suggests that it does help decrease restenosis. It's not hardcore data, but it's pretty good data, and I use it, and I've had some success with it. Clearly, he'll be on Plavix for at least 1 month, if not longer. There is some ideas that we could put him on it for a lot longer time. He clearly needs to have a statin drug. I think that's been the most difficult thing in some patients, is keeping them on their statin drugs. And so those are, and aspirin, obviously aspirin, and if I can get him to give up his cigars, I think it'd be pretty good too.
Frank, thanks for a great case. Lovely job. For the audience, there's a little tiny dissection there. With drug-eluting technologies like balloon, typically those heal pretty well. That's not the same as if we leave those in just a plain balloon intervention. Frank, thank you so much. Look forward to seeing you a little later. Great job.
All right, thank you very much. Thank you.
Next, it's indeed an honor to invite our next